Good morning, class. This morning we'll be learning about neurological disorders. Our first disorder will be meningitis. So meningitis is a neurological disorder that can vary in symptomatology between age groups. So be sure when you're studying in your book that you go through all of those symptomatologies for each age group. Today we're going to focus on a 14-year-old, but just know that any of those age ranges could be mentioned on your test. So let's start with our case study. A 14-year-old male child arrives at the emergency department with complaints of a headache, nausea and vomiting, fever and chills, and just feeling really bad. The nurse performs an assessment on him and gathers his history. So looking through our history here, his temperature is elevated, pupils are reactive but sluggish, that's not normal. His neck is stiff to movement and somewhat painful, so that's abnormal. No other abnormalities of the head or skull. His throat is slightly red, but there is no exudate noted. Heart, respiratory, everything's fine there. Moving along. Abdomen soft, non-distended, and he has active bowel sounds. Musculoskeletal, we have some abnormality here. His upper extremity joints are stiff, but he doesn't complain of any pain when we move them for him. Skin, petechial rash all over his trunk and extremities. So that's a sign of a type of meningitis that we'll talk about, but that is a definite sign of meningococcal meningitis. History, parents state that he has not been away from home or out of the country recently or around any ill contacts. When asked, he says one of his friends went home from school yesterday with a fever, sore throat, and complaints of aching in his arms and legs. He tells the nurse that he plays varsity football for his school and runs track in the off season. No other pertinent history reported. So based upon these findings, what would the nurse's first action be? We're going to have to immediately place him in isolation for meningococcal meningitis. So immediately be placed in isolation for 24 hours, droplet precautions. So if a patient like this comes to the doctor's office or to triage and you're working and you see a rash like this, definitely we need to alert our doctor on staff, our healthcare provider on staff, and tell them that we have this sort of rash and the patient would be moved immediately back to a room. So meningitis, again, we're talking about our positive Kernig's and Brudinsky signs on the patient. So how would these tests be done and what results would help validate the probable diagnosis? So what is the probable diagnosis? We talked about that, meningococcal meningitis. So we've got a picture here of illustrating Kernig's sign and Brudinsky sign. A positive Brudinsky sign is when you flex the extremities, the neck immediately will flex in reaction to that. Positive Kernig's sign is a resistance to the extension of the child's leg from a flexed position. Other words, it will not straighten, the leg will not straighten without considerable pain. So the patient is admitted to the hospital and IV antibiotics are ordered. What other nursing interventions would be implemented? So let's go through this list and we'll select all that apply. Place the patient in reverse isolation. No, we're going to place the patient in droplet precautions for per the CDC for 24 hours. We don't need reverse isolation because that would be protecting the patient from us. We need to protect ourselves from the patient and his diagnosis. Offer the patient small, frequent feedings and drinks. Yes, nothing. We need to watch his level of consciousness. We don't want him to aspirate. Should his intracranial pressure increase and he should lose some of his level of consciousness, that we would not want him to aspirate. So just offer small sips of water, ice, things like that. Keep the lights low in the room and quiet. So we want the room quiet and the lights low because he probably has some photophobia associated with his meningeal irritation and the increased intracranial pressure. So we want to keep the room dark and quiet, and of course no visitors at this point unless it's just immediate family because of his isolation status. Elevate the head of the bed to 45 degrees. Use several pillows to promote neck comfort. No, slightly elevated, no more than 30 degrees, just to promote the draining of the CSF fluid. Recommend side lying for comfort. That is fine. Implement seizure precautions, yes, because we're worrying about increased intracranial pressure. So what are we going to do here? We're going to pat our side rails, make sure we have suction and oxygen available, make sure there's nothing in the bed that the patient could move around and hurt themselves on, have all of our precautions in place. We can go ahead and put the suction and the oxygen at the bedside. without the doctor's order, just to have it available. Keep the room warm since the patient is having chills. Now we want to keep the room cool for comfort. We want to get that fever down. So the doctor writes the following orders. Which ones would the nurse question? Make the patient NPO if there's a change in the level of consciousness. Yes. We would not question that one. Lumbar puncture, set up the room and give midazolam 2 milligrams IV just prior to the procedure. So that one's good. So we would not question that. Vital signs with neuro checks every 4 hours. No, we would question that because we need to be doing vital signs and neuro checks at least every 2 hours. Vancomycin 1 gram IV Q12 hours, that's fine. Clindamycin 650 milligrams IV Q8 hours, that's fine. Maintain O2 levels at 895 or above, that's good. Strict INO, yes. Dexamethasone 30 milligrams POBID. No, that we want to question that because the route, we would want to give that IV just to get it to act more quickly. We want to get that swelling down, the cerebral edema to decrease. Acetaminophen 650 milligrams PO, Q4 hours, PRN discomfort or fever. No, per your book, they recommend Tylenol with codeine. So nothing as strong as morphine because it could mask our pain, which goes to mask our level of consciousness, which goes to our next order here. Morphine sulfate 4 milligrams IV, Q1 to 2 hours for severe pain. So like I said, Tylenol with codeine is the more appropriate pain medication because the morphine is going to mask our level of consciousness or any changes that we have. So we want to be able to determine if the patient is non-responsive because they've had morphine or non-responsive because their condition is worsening. So now we're moving along to Reye syndrome. So let's figure out our risk factors for Reye syndrome and our causes. So sometimes we don't even know the cause, but let's read our statement here. Which of the following statements about Reye syndrome are accurate? So in other words, they are correct. Peak occurrence of Reye syndrome is during the summer months. No, that's not accurate because it occurs most commonly during the flu season, which is January to March. The exact cause of Reye syndrome is not understood. We don't always know what causes it, but we have some ideas. Reye syndrome is associated with taking acetaminophen for fevers associated with viral infections. No, it's aspirin. We don't ever want to give aspirin to a child who we suspect may have Reye syndrome or a child that has a fever, especially associated with any viral infections. Reye syndrome is often mistaken for other disorders. Yes, it can be because the symptoms are very similar to other neurological disorders. Reye syndrome most often affects the kidneys and the liver. No, it most often affects the liver and the brain. So our right answers here are the exact cause of Reye syndrome is understood, and then Reye syndrome is often mistaken for other disorders. So those two statements are accurate. So which findings validate the diagnosis of Reye syndrome? So physical assessment findings. We have lethargy, irritability, combativeness, confusion, delirium, profuse vomiting, seizures, loss of consciousness. So that does mimic a lot of our neurological disorders that we will talk about today. But the commonality that we see though with Reye syndrome is the child has had some sort of viral illness recently and has been given aspirin, or it can be just the viral illness that could cause the Reye syndrome. So those symptoms are very similar to many others. So that's the difficulty with diagnosis. So let's talk about our Reye syndrome case study patient, Jeremy. He's a 6-year-old boy who had the flu last week and presents at the pediatrician's office with the following symptoms. He's very lethargic, he's combative, having intractable vomiting, meaning he just vomits constantly, and is confused as to who he is or who his parents are. The pediatrician quickly realizes that there is something serious going on and sends the child to the local pediatric emergency department. Upon his arrival, he is more disoriented and delirious. His weight is 22 kilograms. So I have a little diagram. Hopefully this will help you remember in your mind some of the features of Reye syndrome here. So encephalopathy, so we have a brain dysfunction with liver damage. It's extremely rare, occurs in children ages 4 to 12. No aspirin plus a child with flu or chickenpox would equal to Reye syndrome. So in our history, we'll see if the child's had any aspirin or if the child has had flu or chickenpox or any viral illness recently. So labs are drawn. Which of the following results are indicative of Reye syndrome? So serum ammonia is elevated, yes, because of our liver involvement. PT and PTT prolonged, yes, because of our liver involvement with our clotting factors. CBC, white blood cell is 8,000 platelets within normal limits, so that's not significant or indicative of Reye syndrome. Glucose 49, that's a little low, but it's not necessarily a sign of Reye syndrome. AST and ALT elevated, of course, those are our liver enzymes, our pancreatic enzymes, lipase and amylase, they're elevated, and our sodium is 145. So you can see in red, I've put in red the ones that would be elevated or affected by Reye syndrome. So which interventions would be appropriate for the nurse to implement in caring for Jeremy? Select all that apply. Maintain strict INO. So we want to do that, of course. We're going to monitor his urine output in milliliters rather than occurrence. So that meaning that we're going to give him something to measure his urine in, and since he's a male, a urinal would be fine. We just want to make sure how much urine output he has. Keep the head of the bed elevated at 30 degrees, yes, because that helps with the drainage of our CSF fluid, helps keep that cerebral edema at bay. Have the child perform range of motion on lower extremities every 4 hours. No, we're going to keep him still. Keep him in a neutral position with no extreme flexion, extension, or rotation. Insert a Foley catheter if it's at the point where he can't go to the bathroom by himself, or we're having a decrease in urine output and his condition is changing, we would insert a Foley catheter. Hold pressure on lab sites for 30 seconds after each blood draw. No, we're going to hold pressure, closer to 5 minutes. 30 seconds wouldn't be enough. Remember, our PT and PTT are prolonged, so we want to hold pressure to prevent bleeding from those sites. Administer mannitol IV per orders. Yes, that's our drug for increased intracranial pressure. We'll talk a lot about that one today. So we are going to administer the mannitol. Give vitamin K, 20 milligrams IM times 1 now. No, vitamin K is typically given sub-Q. Acetaminophen suppository, 650 milligrams PR every 4 hours PRN pain for fever greater than 38.3. No, we would not want to administer anything rectally because of the risk of bleeding. It's a very vascular area down there, so we don't want to be administering anything rectally if we can avoid it. So nursing care for Reye syndrome. So I have my little guy there with the big head. He's saying mannitol stat before this brain swells anymore. So mannitol is our medication. So maintain hydration while preventing cerebral edema. So it's a fine line of maintaining our hydration status but not giving too much fluid that would cause our cerebral edema to worsen. So administer IV fluids as prescribed, maintain accurate INO, insert indwelling urinary catheter as ordered. So positioning the client. So we are going to position them with at a 30-degree head of the bed, elevated. Avoid extreme flexion, extension, or rotation. Maintain the head in a midline neutral position. All of those things will help decrease our cerebral edema. Nursing care Reye syndrome. So monitor coagulation and prevent hemorrhage. Note unexplained or prolonged bleeding. Apply pressure after procedures that cause bleeding. And for how long? At least 5 minutes. So continue nursing care of Reye syndrome. So we're going to monitor pain status in response to painful stimuli. So that's again checking with our level of consciousness. If the patient is not responding to any other stimulus, sometimes pain is our only stimulus and we got to make sure that they are still responding to pain. Administer pain medications when appropriate. Assist with intubation and maintain a ventilator if required. Implement seizure precautions again for our increased intracranial pressure. Head of the bed. We make sure that we keep the bed rails are padded. We have oxygen suction at bedside. We make sure that the patient doesn't have anything in the bed that could be harmful or hurt them when they would start having a seizure. And of course, after the seizure, we would just turn him on his side to make sure that we don't have any aspiration if he should vomit. Keep the family informed of the client's status. This is a very serious disorder. We want to keep them up to date on everything that's going on with their child. Provide private time to the family to be with the client if death is imminent. Yes, death is a possibility. This is very serious, so we're going to provide private time for the family to be with their child. Initiate referrals to support resources for family. Of course, we can have some long-term if the child survives, we can have some long-term neurological issues. So we are going to provide support whether the patient, of course, should survive this or should they not. We're going to have support for the family. So here's our medications for Reye syndrome. Osmotic diuretic mannitol. So that is for our cerebral edema. So we're going to constantly monitor our cerebral edema and our ICP. The patient will probably have a monitoring device that goes directly into their skull, so we'll be able to monitor their intracranial pressure to see if our mannitol is being successful in treating the patient. Vitamin K, it improves the synthesis of blood clotting factors in the liver. So since our liver is being depleted of all of our clotting factors, we're going to give vitamin K to promote coagulation. So again, subcutaneous is our preferred route, and identify client sensitivity to benzoyl alcohol or castor oil. That's the agent in which the medication is distributed and dispersed. Client education, teach the family about dietary intake of vitamin K, so they want to keep an eye on that. So interprofessional care, Reye syndrome. So we have a client who has neurological deficits post-Reye syndrome requiring interventions from other members of the healthcare team. So occupational therapy and physical therapy to help the patient adjust and adapt to their neurological deficits, and a dietitian might be needed to assist in maintaining adequate hydration. So teach parents to avoid giving salicylates for pain or fever in children. Teach parents to read labels of over-the-counter medications to check the presence of salicylates. So we're going to read other labels because we could have aspirin in many different medications. So teach the parents to always read the labels on any medicine, especially the ones that have medicines in them. Make sure they read the label. Also teach the family that clients will regain full liver function but can have some neurological deficits. So just a little review with a narrative here and also an illustration to help you remember Reye syndrome, and the aspirin is the bad guy. So you can see his face, he's mean. So no aspirin for Reye syndrome. So risk factors and complications. So what are the two risk factors? Just a review. Giving aspirin to a child with fever and also viral infections. So complications, again, liver, it usually returns to full functioning, but we do have some neurological deficits after the child recovers. So complications vary by degree of severity. So how severe was our illness, how long the duration, how much cerebral edema did we have, so lots of factors. So sometimes it includes speech or hearing impairment and developmental delays based on the length and severity of illness. So next we're going to be talking about head injuries. And our head injury case study is about Angela. Angela is a 12-year-old girl who was ice skating at a local ice skating rink with her mom and sister when she fell and hit her head on the ice. Mom said that Angela never completely lost consciousness, but she appeared confused and pale immediately after the fall. The attendant working at the rink then called 911. Angela arrives at the emergency department. She is drowsy but arousable. Her pupils are equal and reactive at 2 to 3 millimeters. Her vital signs are as follows. Heart rate is 80, respiratory rate 18, BP is 102/64, and temp is 37 degrees Celsius. So that all looks fine. Based on the findings that we just discussed, what type of head injury does Angela have? So at this time we have a concussion. So let's briefly have a review of the types of head injuries. We determined that Angela has a concussion. So a concussion is a traumatic injury to the brain that alters the way the brain functions. This is more of a minor injury. Contusion is bruising of the cerebral tissue, maybe where the skull has moved around in the brain has moved around in the skull and caused some bruising. Lacerations is a tearing of the cerebral tissue, and fractures, again, that's where our skull fractures can be linear, depressed, comminuted, basilar, open, or growing. So head injury progression. Let's talk a little about progression before we start talking about Angela a little more. So Head injury progression, we have a minor injury where we have possible loss of consciousness, temporary period of confusion, vomiting, pallor, irritability, lethargy, and drowsiness. So that's a minor injury. Angela had a few of those symptoms there. Progression of injury, so this is a marked change in vital signs, altered mental status, focal neurological deficits, increase in agitation. So we're progressing worse from probably having a minor injury. Severe injury, we have increased intracranial pressure to the point of where we can have, death with this. So severe injury, we're more concerned, but even with minor injuries, they can progress. So labs and diagnostics, what kind of labs are we going to be drawing? Arterial blood gases, blood alcohol and toxicology screening. Hopefully Angela was not drinking at the skating rink, but we always check any kind of blood and alcohol toxicology screenings because that could affect to our level of consciousness. CBC with differential liver function tests. Diagnostics, of course, a cervical spine x-ray to rule out cervical spine injury. We're going to have a CT or an MRI, which is more diagnostic of the level of head injury we have and if we have any bleeding. Just a side note, our ICP normal range is from 1 to 10, and anything greater than 15 requires further assessment. So we're back to Angela. Mom brings the child to the emergency department following her inability to arouse the child the next morning at home. So her pupils are sluggish to react. She continues to vomit and she doesn't seem to understand simple commands. She's admitted to the floor for observation and monitoring. Which interventions would the nurse implement in her care? So select all that apply. We're going to keep the bed flat for comfort. No, we're going to elevate the head of the bed at 30 degrees because that helps with our CSF drainage. Keep the child's head and body in midline neutral position. Again, that helps if we have any increased intracranial pressure, cerebral edema. Limit visitors and keep room quiet. Again, that helps with our increased ICP. Pad side rails and keep them up at all times. Safety precautions, again, for seizures. Encourage the child to be up in the chair and walking the hall every shift. No, we want to decrease activity because that, an increase in activity will increase our ICP. So nursing care, we're going to focus on our implementing nursing care here and what we can do to help, especially focusing around our increased intracranial pressure. So number 1, implement actions that will decrease ICP. All the things we've talked about, positioning in the bed, the head of the bed at 30 degrees, no extreme flexion or rotation, extension, make sure that the room is dark and quiet, all of those things to implement actions to decrease our ICP. So I just mentioned this, keep the head of the bed midline with the head of the bed at 30 degrees, which also promote venous drainage. Avoid flexion, extension, rotation of the head, and maintain in a midline neutral position. So keep the patient's body in alignment, avoiding hip flexion or extension. Minimize oral suctioning. Nasal suctioning is contraindicated because, again, the nasal suctioning will increase our ICP. So we can gently suction the mouth with a Yonker suction, but we're not going to go up. We're not going to do anything through the nose. Instruct the client to avoid coughing and blowing the nose because these activities will increase ICP. So all of those things we're focusing on decreasing our ICP or making sure it doesn't go any higher. So all of those nursing actions are very important for you to implement if you have a patient you suspect with increased intracranial pressure. Let's discuss complications that can occur with a head injury. In Angela's case, she did progress to a more serious situation, so it could be any of these three things we're talking about here with complications, that we initially have a minor injury that progresses and becomes something more serious. So epidural hematoma, bleeding between the dura and the skull. Manifestations, short period of unconsciousness. So whenever you're talking to whomever was on the scene, you need to make sure you ask them if the patient was unconscious and for how long. So followed by a normal period for several hours, then lethargy or coma due to blood accumulation of the epidural space and compression of the brain. Subdural hemorrhage, so bleeding between the dura and the arachnoid membrane. So might be a result of birth injury, falls, or violent shaking. We see this oftentimes with shaken baby syndrome. Manifestations: irritability, vomiting, increased head circumference, lethargy, seizures, coma. Cerebral edema can develop within 24 to 72 hours post-trauma. So that again is the situation with our case study, Angela. We had some cerebral edema develop later on after the child went home. So manifestations: increased ICP, changes in the cerebral flow. Brain herniation, that's our most serious complication. That's the downward shift of the brain into the foramen magnum. The whole brain is just basically sucked through that big opening. So this results in death. Manifestations: loss of blinking, loss of gag reflex, pupils fail to react to light, systemic hypertension, subdural hemorrhage, bradycardia, coma, and respiratory arrest, so resulting in death. Let's discuss cerebral palsy. Before we get to our case study, I'm going to give you a few facts about cerebral palsy. So cerebral palsy is a non-progressive impairment of motor function, especially that of muscle control, coordination, and posture. Cerebral palsy can cause abnormal perception and sensation, including visual, hearing, and speech impairments, seizures, and cognitive disabilities. CF manifests differently in each child. The severity is going to be worse, symptoms are going to be worse with every child. Developmental outcomes will vary and are dependent on the severity of the injury. So our case study is Michelle. Michelle was born at 27 weeks gestation, weighed 2 pounds 8 ounces, and was in the NICU for 4 months. She was on a ventilator for 3 of those 4 months. She was the second born of fraternal twins, suffered an intraventricular hemorrhage at 3 weeks of age, had numerous hypoxic episodes during her hospital stay, was slow to gain weight, and was a poor feeder until 2 weeks ago. She is now ready for discharge, weighing 5 pounds and 2 ounces. So what parts of Michelle's history would be contributory to the diagnosis of cerebral palsy? So prematurity, low birth weight, possible anoxic events, meaning that she at some point or another her brain was deprived of oxygen, and multiple births. We can have complications with multiple births. Any multiple birth is always considered for the labor and delivery, almost like an ICU patient. So progression of case study or diagnosis. So Michelle has several follow-up appointments with PT, speech therapy, and the neurologist due to her history of prematurity and an intracranial bleed. At 7 months of age, the PT noted that Michelle was hyperreflexive and hypertonic and was rather stiff and choked on her feeding easily. Speech therapy found that Michelle had a persistent tongue thrust and poor suck reflex. She has had poor head control and is not meeting her developmental milestones. She is diagnosed with cerebral palsy. So Michelle, look, we have other symptoms here, and we're going to discuss them kind of as we go along. I have an illustration for you here. Failure to meet milestones, that's a big one. Persistent primitive reflexes, gagging or choking with feeding, poor suck reflex because we have poor head control. Tongue thrust, which also contributes to the inability to feed. Poor head control, rigid posture and extremities, abnormal posturing, asymmetric crawl, vision or hearing impairments, and seizures. Nursing intervention. So the earlier we intervene in this case, the better the outcome for the patient. As I mentioned before, this is not a progressive illness or disorder. It is what it is when the child is born and will not progress. Cognitively, there's going to be variation, so we're going to look at the patient, every patient individually, and assess their abilities. So right now we're looking at early intervention with supporting therapies. We're going to individualize care to meet client needs. Like I said, every client's going to be a little different with their level of severity and their developmental delays. Monitor developmental milestones. So we might need to know exactly what's expected at this age. So know what is expected at the age of the child that you're providing care for, so you'll know how far along they are, how we might need to intervene, maybe have to increase our level of care. Evaluate the need for hearing and speech evaluations. Promote independence with self-care activities as much as possible. That helps with independence, that helps with confidence. Assess the child to maintain a positive self-image and a high level of self-esteem. Determine the extent of family coping and support. And there's a lot involved here, all the different therapies, there's a lot of money. There's also a lot of psychosocial issues surrounding the child having, delays. The parents feel guilty. There's a lot of psychosocial issues going on here. So progression of the case study, feeding Michelle. The nurse is providing instructions to the parents on how to best feed Michelle to minimize her choking. They would be told to, so we're going to go through these, feed her only liquids, not solids. No, we want to start her with solids eventually when it's time. Use a nipple with a large hole to make it easier for her to suck from. Now we don't want to do that because that would probably cause her to choke just because of the amount of fluid that's coming into her mouth at the same time. Hold her head and jaw as you feed her to help her swallow better. Yes, so you would support the head, support the jaw, and make sure you're holding her in an upright position so she doesn't aspirate. Lean her back with feeding to ease swallowing. No, again, I just said we would have her at an upright position to eliminate the possibility of aspirating. So now let's discuss medication management for Michelle. Michelle has started on medications to help with her cerebral palsy. The doctor prescribed baclofen leoracil for her. The parents ask how this medication works and how it will benefit Michelle. You reply, baclofen is a sedative and by sedating her, she will be more relaxed. No. It is a skeletal muscle relaxant that will reduce her spasticity. That is correct. Baclofen works specifically on lower extremity hypertonia. No, it works on all of her muscles. Patients that take baclofen seem to be calmer and have a reduced chance to have seizures. No, this has nothing to do with seizures or the child's demeanor. Identify the disciplines involved in Michelle's care. How would each discipline help her? PT, that would help with her spasticity, her muscle issues. OT would be learning how to do daily activities along with recreational therapy. And that's kind of like a play therapy. Education, of course, we're going to have either a teacher coming in, teaching Michelle according to how severe her cerebral palsy is, or she might be able to go to school on a daily basis. It's according to how the severity of her illness. Surgical interventions, there might be surgical interventions for muscles that have contractured. We might have to go in and do fasciotomies on muscles as the child grows. So all of those disciplines all work together to help Michelle progress. The next neurological disorder we will discuss is spina bifida. I'm going to read through the case study and then we'll talk about the different types of spina bifida. Sean was born 2 hours ago to a 19-year-old mother who received prenatal care all throughout her pregnancy but did not have an ultrasound. Sean was full term and weighed 8 pounds and 4 ounces. Immediately after delivery, it was noticed that a protruding sac on his lower back that was enclosed in a thin layer of skin. When the sac was examined closer, it appeared to contain fluid, nerves, and other neural material. Additionally, Sean is noted to have a bilateral clubfoot. Remember, we talked about clubfoot in our musculoskeletal lecture, and it commonly accompanies different disorders, and one of them is spina bifida. Spina bifida is a failure of the osseous spine to close. Neural tube defects are present at birth and affect the CNS and osseous spine. So I have a picture of fetal development here, and you can see where the defect is and where it didn't close on the last picture. Types of spina bifida. So we have spina bifida occulta, mostly occurs and affects the lumbosacral area and is not visible, so it's hidden. Spina bifida cystica, protrusion of the sac is visible. I don't have a picture of that, but it's similar to the occulta, but you can actually see the sac in this case. Meningocele, the sac contains spinal fluid and meninges. In myelomeningocele, the sac actually contains spinal fluid, meninges, and nerves. So we have everything is protruding out from between the vertebrae. So what neuromuscular defect does Sean have? He has a myelomeningocele, and then I gave you a pretty good little diagram there of normal anatomy. Then the myelomeningocele, you can see where we have a Chiari malformation, which is affects fluid building up in the child's skull, so we'll end up with hydrocephalus if we have an Arnold-Chiari malformation. And then there's a picture after fetal surgery. So you're the nurse taking care of Sean. What is your priority nursing action? So cover the sac. We want to make sure we keep the sac moist and covered and protected from the environment, protected from infection, protected from drying out, and also implement latex precautions immediately. Which risk factors contribute to this problem? So select all that apply. We're going to go through the whole list here. Advanced maternal age. No, this is more likely related to Down syndrome, not spina bifida. Maternal malnutrition, and that goes into lacking the folic acid during pregnancy. So maternal malnutrition, lack of folic acid. Medications taken while pregnant. Yes, there are certain medications that are tetragenic. Exposure to radiation or chemicals during pregnancy. So all of those are correct. Alcohol consumption, no. The more, we see this more with fetal alcohol syndrome. It's not good to drink at all with babies, but with spina bifida, we're more concerned about the folic acid deficiency. Let's gather some assessment data on Sean. So what assessment data would be important to gather for Sean to help in determining his care needs? Head circumference, that is important because we can have some accompanying hydrocephalus with the interruption in the flow of the CSF. Urinary output, according to the level of the malformation, we can have issues with the child not being able to urinate. Rectal temperature, we're not going to get a rectal temp because again that could cause a rectal prolapse with Sean. Feeding volume, that's not particularly important right now. We're going to be sending him to surgery. We're not going to be concerned with how much he's eating. Stooling pattern, again that happens with the level of the deformity at the level of the spine that innervates those nerves to the GI system. So we could have a change in stooling pattern. He could even end up needing a colostomy. Movement of lower extremities, again with our nerve innervation, and if he can move his lower extremities. So those would be pertinent. So head circumference, urinary output, stooling pattern, and movement of the lower extremities. Progression of case study Sean. It is noted that Sean's head circumference is 36, the anterior fontanelle is full, the sutures are open, and the infant has a prominent bulging forehead. Hydrocephalus is suspected. What test is used to validate this diagnosis? So we have some prenatal and postnatal tests that we can use for Sean. So prenatally, we would be checking mom's alpha theta protein during pregnancy. So 16 to 18 weeks, we can do that. Also do a cranial ultrasound and check an amniocentesis. After Sean is born, an MRI, ultrasound, CT, we would detect any anencephaly associated with the myelomeningeal. We could see that more closely. Also, we could see the disruption of the flow of the CSF to see if we have hydrocephalus. It is confirmed that Sean has hydrocephalus along with spina bifida, and the surgery is scheduled for repair of both of these tomorrow. In the meantime, what pre-op care would the nurse provide for Sean? So we're going to surgery in the morning. So let's look at our selections here. This is just one we need to select here. Hold and feed him every 4 hours. No, we're not going to hold and feed him because especially if we put pressure on that sac, we could rupture the sac. So no, we would not hold him and feed him. Keep the defect covered with moist, sterile, non-adherent dressing. Yes. Place the infant on his side with a roll behind him. No, we're going to have him, which goes on to my next one, place him prone with the legs straight and hips adducted. No, we want the hips flexed and the legs abducted. So we're going to show you a slide now with an illustration of positioning. So the correct answer was to keep the defect covered with a moist, sterile, non-adherent dressing. So you can see again another diagram on the type of of defect that Sean has, the myelomeningeal, and we can see the way he's positioned there, kind of like little frog legs. So progression, post-operative. So Sean has returned from surgery the next afternoon. He has an IV infusing and a dressing on his back from the spina bifida repair and incisions on the abdomen and skull from a shunt placement. What would the correct position be to place the infant in? So right now we're going to keep him prone until the doctor tells us otherwise. So prone until other positions are prescribed. More post-operative care. What nursing actions would be implemented in caring for Sean post-operatively? Select all that apply. Perform active range of motions on Sean's extremities. No, we'd be doing passive range of motion. Monitor Sean's voiding and stooling pattern, again, because we have to see it if he's going to stool and have urine output based on the level of nerve innervation affected with his deformity. Provide pain meds as needed, yes. Begin oral feeding once Sean is awake and alert, yes. Post-operatively, the nurse is assessing Sean and notes that there is some moisture noted on his scalp incision. His incision, again, where we put the shunt. What does she need to do first? So we're going to mark the site and inform the physician that this could be CSF leakage. So mark it so we all know if it's increasing in amount. And then look here at our picture that I have displayed for you. You can see the halo effect on the dressing. So that would mean we have some CSF fluid leaking out. Sean's parents are preparing to take Sean home after his repair and shunt. What instructions would the nurse provide for his parents? Select all that apply. So we're going to go through each of these. Perform in and out catheterizations every 4 hours. Yes, he's going to need to be cath. We've determined that he is having issues with urinating on his own. Monitor for his level of consciousness regularly, noting any changes which should be reported. Yes, that could be a change in our intracranial pressure, so we could have maybe a shunt malfunctioning. Do not place pressure on his op side, on his back and scalp until they are healed. Especially we don't want him on the side where the shunt is, because that leads to the next intervention here. We want to make sure we don't obstruct that shunt in any way. So place him side lying on the shunted side of his head. So like I just said, no, we could obstruct that shunt. So that's not correct. Since Sean cannot move his legs, he will need help when he begins to try to walk like a wheelchair or stroller. Yes, we'd work with our different professional disciplines to help provide a wheelchair or stroller for us. He will need anticonvulsions every day. No. So right now we don't have any evidence that he has any kind of brain trauma or seizures. We're going to hope that shunt works and we don't get increased intracranial pressure and cerebral edema that could lead to seizures. Sean may develop latex allergies, so remember to report this all to all of our healthcare providers. Any healthcare provider he sees needs to know his history of latex allergy. Sean needs to be evaluated regularly to see how he is progressing developmentally. Yes, constant evaluation and early intervention are key in helping Sean. If you notice that the urine is cloudy, it has an odor or blood in it, this is anticipated and they should not worry. Now, we're going to tell the parents that this could be a UTI. Anytime we see blood or cloudy urine, we're thinking of a UTI infection. So we want to make sure that the parents know when they're cathing Sean to be looking out for those findings. This will conclude our neurological disorders lecture. I have included an illustration here that talks about the level of spinal nerves and how the location of Sean's deformity might cause problems with the different levels of spinal nerves. So you can look at that and use that as an illustration if you need to. Also, if you have any questions, we'll talk about this during our Q&A, so be sure to write your questions down and go back through your notes and have questions ready for me. So anyway, have a great day. I will talk to you later.